Bismillahirrahmanirrahim. So in the stroke series, this is the last video. So I have already gone through the different types of anterior circulation strokes, right? So I have discussed about the cortical strokes, then I have discussed about the posterior circulation strokes of the midbrain, bones and medulla. I have briefly gone through the all the type of strokes. So let's discuss some clinical scenarios related to this and management of the stroke in this last video, right? So let's discuss the a case of vertebrobasilar TIA, right? Transient ischemic attack. So this is actually because of the partial occlusion, and this is very common. So what happens? So brain stem is involved in this case, midbrain, bones and medulla, right? So we do have the motor and sensory tracts running through this, plus we will have the features of cranial pulses, right? And cerebellum will also get involved in this case. So there will be imbalance in coordination, there will be dysmetria and ataxia, right? And posterior cerebral cortex is also involved. We know that the P2PCA is going to supply the posterior cerebral cortex, the occipital lobe. So homonymous heminopia will be one of the feature of the vertebrobasilar TIA. So let's discuss a case related to that. So a 57-year-old smoker has presented with complaint of repeated attacks of the right side is hemiparesis, sensory loss, right, vertigo, imbalance in coordination along with cranial nerve pulses for last 18 hours. So this thing, right, and imbalance, vertigo, coordination, in coordination. So these features and you represent the problem is in the brain stem, right? The problem is in cerebellum. So we're gonna think about that the patient is having vertebrobasilar TI, right? So I have discussed the locked-in syndrome, that is also called as pseudocoma. So basically, patient is prisoner in his own body. So this is because of the complete occlusion of the basilar artery, right? So let's discuss a case about it. So 53-year-old diabetic has presented with sudden onset of quadriplegia, right? So this patient is having quadriplegia and bilateral sensory loss, right? And and also multiple cranial pulses and nystagmus. I just talked about one thing, that the only movement that is possible in these patients is the vertical eye movement, right? Vertical gaze is intact in these patients, and rest is gone away, right? So patient is having quadriplegia. Patient won't be able to eat, drink, right, and talk, right? Right, so this is a case of complete basilar occlusion, that is also called as locked-in syndrome, right? Okay, so let's discuss another case related to pica, right? Right, so in the pica, this is also called as lateral medullary syndrome, also known as Wallenberg syndrome, right? Weber syndrome is present in the Weber syndrome is described as the ipsilateral third cranial palsy and contralateral hemiplegia. That is a basically syndrome of the midbrain, right? So this is Wallenberg syndrome, right? So this is also known as lateral medullary syndrome, right? So in the Wallenberg syndrome, I draw, in the last video I have drawn the medulla like that. So we'll have the olive, pyramid, then olive. Okay, and we have the restiform body, we have the descending sympathetic pathway, then we'll have the sensory component of fifth cranial nerve, right? And then we'll have the lateral spinothalamic tract, and eighth cranial nerve is there, right? And we'll have nucleus abstractus solitarius and nucleus ambiguous. So if there are multiple cranial pulses, right? So we're gonna think that the patient is having lateral medullary syndrome, right? So basically, pica is gonna supply the posterior and inferior surface of the cerebellum, and also gonna supply the lateral part of medulla. So lateral medullary syndrome or Wallenberg syndrome is basically mostly it happens because of the vertebral artery occlusion, right? And and also can also lead, happen because of the pica occlusion, right? So we have the 7th 5 plus 7 plus 9 plus 10 plus 11. So all of these cranial nerves are involved, along with that restiform body, along with that the spinothalamic. So we see the crossed hemi anesthesia in these patients, crossed hemi anesthesia, right, in these patients, right? Okay. So let's discuss a case about it. So a 61-year-old smoker has presented with sudden onset nausea, vomiting and vertigo, imbalance, right? So these are the features of the cerebellar involvement, right? So patient is having dysphagia, that means ninth and 10th and dysarthria. So this represents 9th and 10th involvement. So this represents the cerebellar involvement, right? Examination revealed right-sided ptosis, right? So patient is having ptosis, meiosis and hydrosis. So this is a feature of Horner syndrome, right? And a pain and temperature loss, right? So that means lateral spinothalamic tracts are involved. So this is a case of Wallenberg syndrome, right? Okay. Let's discuss a case related to the medial medullary syndrome, right? So antispinal artery is gonna involve in this case in these patients. So we'll have the features of 12th, mainly the 12th cranial nerve, right? So patient is gonna have the tongue division, right? So let's discuss a case about it. So 52-year-old smoker has presented with right-sided hemiplegia, right, and the tongue paralysis and loss of sense of vibration and joint position, right? So this is basically this is we'll have the medial lemniscus pathway, dorsal column medial lemniscus pathway that are going to present medially and posteriorly, right? Okay, so this is a case of medial medullary syndrome, right? All right. So what happens when there is complete occlusion of the occlusion of the posterior cerebral artery, right? Posterior cerebral, mainly P2PCA portion, right? 61-year-old diabetic has presented with increased pain on the half of the body, along with homonymous heminopia. Right. There are, I would like to add one point here that there are some branches, right? Some branches that are going to supply the thalamus as well, right? So in when there is infarct of that area, so that what's going to happen if there is hemorrhage or infarct of that area. So what's going to happen, there will be a syndrome that is called as thalamic pain syndrome, right, related to this, right? So posterior cerebral artery is also going to supply the thalamus, right? So there is a thalamic pain syndrome related to that. So when there will be ischemia of that, so there will be increased pain on the one half of the body, right? And visual cortex will be involved because the posterior cerebral artery is going to supply the thalamus and also going to supply the occipital lobe. So there will be homonymous heminopia along with macular sparing. The central vision is intact gets intact because of the anterior cerebral artery. Some branches of MCA, middle cerebral artery, also going to supply the occipital cortex. So there is macular sparing because of that, right? So this is a case of posterior cerebral artery occlusion, right? So let's discuss the how we're going to differentiate superior cerebellar artery and anterior inferior, although I have discussed separately in the last video, so I think we can skip this. I have also gone through the cerebral venous thrombosis, so let's get through this in the headache portion. So let's quickly revise this thing, okay? So triggers are basically oral contraceptive pills and pregnancy, and mostly I have seen the postpartum cases with the cerebral venous thrombosis, and it happens because of the our decreased anti-clotting system, that is protein C and S and antithrombin 3, right? So these are also decreased in cirrhosis. So we see mostly portal vein thrombosis in patients with DCLD due to HCV, because of these things get reduced, anti-clotting system get reduced, so there is increased chance of clot formation. And secondly, there is stagnant circulation, and thirdly, there is increased pressure. So because of stagnant circulation and decreased production of protein C and S and antithrombin 3 in cirrhosis, these patients usually get the thrombus in the portal vein, right? So so in these cerebral venous thrombosis, patients might have the deficiency of protein C, S, and antithrombin 3. So there can be a factor 5 Leiden mutation, right? Protein C is basically have antithrombin action. So in these patients, there will be resistance of the action of protein C. So right, and prothrombin G 2021 mutation, right? So this can also happen, right? There is antiphospholipid antibody syndrome, that is alteplase, right? There can be polycythemia, right? So these are the triggers for cerebral venous thrombosis. So we're gonna get these the clinical features of raised ICP, right? So there will be headache, there will be, you know, projectile vomiting, right? And because of the raised ICP, there can be posturing, there can be seizures, hemiplegia, and paraplegia, right? If you get the CT, it can be normal, but sometimes we see hemorrhages and infarcts, together in the mostly in posterior area, in the venous sinuses area, right? So we're gonna get the investigation of choice is MRI, MRV, right? So we're gonna start the injection heparin and warfarin. We're gonna along with that warfarin, we're gonna continue it for 3 to 6 months. So if there is thrombophilia, we're gonna give lifelong aspirin in these patients, right? So that's a treatment for the cerebrovenous thrombosis. This is only condition we see hemorrhages and we give the anticoagulation, right? That is because of the blockage of the sinuses, and that leads to hemorrhage and ischemia in that area, right? So let's discuss the management part in the right. So let's discuss about the management of the stroke, right? So we can have the hemorrhagic stroke, we can have the ischemic stroke, right? All right, so in this we're gonna resuscitate the patient. We're gonna check the airways, breathing, circulations, right? And we're gonna check the RBS. If there's hypoglycemia, we're gonna correct that, and if there's hyperglycemia, we need to correct that. And the very first thing is that we are gonna go for the CT scan, CT brain, right? So CT is gonna decide whether the patient is having hemorrhagic stroke. If there is have hyperdense lesion, so it will be hemorrhagic stroke. If there is, patient has come earlier, so there will be no finding in CT, right? Within, CT for ischemic stroke, it takes almost 6 to 12 hours for the CT ischemic changes to be, in present in the CT brain, right? So initially CT will be normal. So if we repeat the CT after 6 to 12 hours, we can find ischemia in that area, right? So if there is no hemorrhage, we're gonna, and there is a neurological focal deficit, so we're just gonna go for the ischemic CVA. We're gonna treat this patient, right? So it can be normal, right? For ischemic CVA, there can be dense MCA sign, there will be hyper density, just like this one. Just I have drawn this one. There will be hyper density in the MCA territory, right? If we see that, so this is called a dense MCA sign. This is seen in the ischemic CV, right? So what we need to do, if the patient has come, so we have to go for the door to CT scan. CT time should be within 20 minutes, and door to CT interpretation time should be within 45 minutes, right? Okay, so what we have to do for ischemic CVA, we're gonna give the patient dual antiplatelet therapy, right? We're gonna load the patient. All right, so we have to give the aspirin 300 mg stat, right, and this will continue for 2 weeks. If we're gonna, thrombolize this patient, we can give the patient if patient has come within 4.5 hours from the onset of symptoms, we can give these patients retiplase, and retiplase dose is 0.9 mg per kg, right? So maximum dose is 90 mg, right? And for this we can give the 10% in the bolus form, right? And the 90% will be given over 1 hour, right? So right, and after 48 hours we have to start the aspirin again, right? Okay. um so if patient has come in 4.5 to 6 hours, what we can do in these patients is we can go for the mechanical thrombectomy, right? And the procedure is called as mercy mechanical embolus retrieval of cerebral retrieval in cerebral ischemia, right? This procedure is called as mercy procedure, right? So if the patient has come late, so we got the CT scan and there was hypodense area, right? So it is ischemic stroke. So we're gonna give the patient aspirin. We're gonna give the patient 300 mg stat, and then when we admit this patient to the ward, so we have to add 75 mg per day, right? And right, we can also anticoagulate this patient if there's any risk. We usually do not anticoagulate these patients, but if the patient is having atrial fibrillation along with that, if the patient is having clot in left atria, right? So we're gonna add the anticoagulation, right? So we can give the heparin, or we can add on the Clexane, right? Okay, so let's talk about blood pressure control, right? So for that, a target blood pressure it should be more than 160 by 90. We're not gonna decrease the blood pressure in the in CV infarct patients or CV hemorrhage patients, hemorrhagic CV patients, right? So we are not gonna treat the high blood pressures. It should be more than 160. As we know that cerebral perfusion pressure is equal to mean arterial pressure minus minus ICP. So when ICP's intracranial pressure is increased, right? So what happens? The cerebral perfusion pressure, it what happens? It decreases, right? So to maintain this one, mean arterial pressure is also increased, right? So that's how cerebral perfusion pressure is maintained, right? So because of that, Cushing reflex, right? So brain actually tries to um, you know brain tries to maintain its perfume to raise brain actually and increases the blood pressure in when there is ischemia within the brain, right? So very high blood pressure can be slightly lowered, right? So it should be more than 160 by 90. So different textbook mention the different values, right? And additionally, we can go for the NG intubation. We have to catheterize this patient, right? We have to we have to put the NG tube in this patient because there can be some cranial pulses along with that, right? So patient won't be able to eat anything. And another thing is, if um, because of the pseudobulbar palsy and bulbar palsy, there can be dysphagia and there will be risk of aspiration so we have to put the NG tube in these patients, right? And we also need to catheterize these patients. We're gonna check the intake and output monitoring, right? We have to do for that. So while thrombolizing these patients, while giving the thrombolysis with the retiplase, we have to check the symptom. If there is a worsening of symptoms, like if a patient get into the post-ring form, so while giving the retiplase, so in acute ischemic stroke, so there is chance that this has transformed into the hemorrhagic stroke, right? So we need to stop the infusion and we have to give these patients immediately prothrombin complex concentrate, right? And for MI, if we give the if the in the STEMI, if there is the elevation MI and we are giving the SK, right? And there are worsening of symptoms, so we there is SK toxicity. If some bleed happens, if there is uh, neurological focal deficits start appearing in these patients. So it is possibility that the patient has developed the hemorrhagic stroke along with MI. So we need to give these patients ECA, that is epsilon amino caproic acid, right? So for SK toxicity we have to give the ECA, and for retiplase we can give the prothrombin complex concentrate, right? Okay, right. And the fifth thing is that we have to catheterize and put the NG tube. And the sixth thing is that we have to treat the cerebral edema, right? We have to restrict the water intake. We can give this patient mannitol, right? And we can also go for hemicraniectomy if there is um, progressive deterioration of these patients. For subsequent treatment, we have to check the blood sugar level. We need to treat accordingly, and we have to check the lipid profile. Mostly patients have the atherosclerosis, right? And atherosclerosis, because of that, there is stenosis of the internal carotid arteries, and there is decreased perfusion to brain, and that lead to ischemic stroke. So we need to check the lipid profile. We have to get the ECG to check whether the patient is having atrial fibrillation or not. So sometimes there is dilated cardiomyopathy, IDCMP, some ischemic dilated cardiomyopathy. So sometimes patient is having alcoholism, and this is called as non-rheumatic atrial fibrillation, right? So because of the atrial fibrillation, there will be atrials won't be contracting, just like atrials will be vibrating, and there is increased stresses of the blood in the left atria, and there will be increased chance of the clot formation within the atria, right? So we're gonna get that echo done, right? So we can get the transesophageal echo or transthoracic echo, right? To check for mural thrombus, right? So we have to also get the carotid Doppler, right, and check the atherosclerosis. Also need to check the homocysteine level, right? Okay. so for secondary prophylaxis we have to treat the risk factors. Let's move on to the next page. So there will be all right, so we have to counsel these patients for the outcome. There's 20% mortality within 1 month, and 10% mortality within 1 year, right? So weakness can improve after 6 weeks, right? It takes 3 to 6 months mostly, right? And less than 40% will have complete recovery, right? Very less um, number of people are gonna get the complete recovery from weakness, right? So consider and carotid on endarterectomy, right? We place mostly in these days, we place the endovascular stenting in these patients if there is more than 70% bilateral internal carotid artery stenosis. Previously the endarterectomy was done, right? So, and the another thing is good nursing care. We have to ensure the good nutrition. We have to calculate the according calories per day, right? Requirement per day, and we can initiate the TPN in these patients, right? Or we can go for NG intubation, and we can give the oral, right? So for NG intubation, feed should be done at 45 degrees. Keep patient at 45 even 15 minutes after feeding, because there is a risk of aspiration. Mostly these patients die of complications like aspiration pneumonia. So we have to take care of the DVT. We need to put on the compression stockings, right? And prophylactically we need to give the subcut heparin in these patients, and subcut clexane in these patients. We have to take care of the skin. We need to prevent the bed sore formation by frequent change of posture, and by applying ripple layer mattress, right? In these patients, have to take care of the eyes and bowel and bladder, right? For eyes, taping of lids should be done, right? So eyes can remain open. There is increased risk of exposure keratitis, so we have to tape the eyelids, right? So we can also go for tarsography in these patients. For bowel laxative and soft diet can be used, right? Because Also, when there is constipation, so when the patient's strength, there is increased risk of raised ICP in these patients, so we need to add the laxatives and soft diet to these patients, right? For bladder, we need to catheterize with the silicone catheter that is in blue color, right? So it should be replaced after 2 weeks. It can be replaced after 2 weeks. If foliage is basically, the other one is yellow in color and there's increased risk of infection with that, so we can put on the silicone catheter, right? And the last thing is physiotherapy, right? So that's going to help to reduce the contracture in these patients and muscle weakness, right? So that's all about the strokes. So let's talk about little bit about the management of transient ischemic attack, right? All right, for TIA, we need to calculate this score, right? If any patient is presenting with the neurological focal deficits that improve within 1 hour, so we're gonna think about TIA. We have to calculate this score that is called as ABCD2 score, right? A stands for age. If it is more than 60, so 1 mark. Blood pressure is, if it is more than 140/90, 1 mark. Clinical, C stands for clinical features, like patient is having hemiplegia, 2 marks. Speech deficit, 1 mark. If duration is more than 1 hour, so we're gonna give the patient 2 marks. If it is less than 1 hour, we're gonna give the 1 mark. If the patient is having diabetes, then we have to give the 1 mark. So D2 stands for duration and diabetes. So score of more than 7, it represent 22% risk of complete stroke in less than within next 2 days, within 48 hours, and 35% risk within 7 days, right? So if the patient is having score, if a patient comes along with the focal deficits that remain for less than an hour, so we need to calculate the score. And if the score is more than 4, so it should be seen by consultant within 24 hours. And if score is less than 4, so we can send this patient to the OPD, and we can ask the patient to get himself checked from the neurologist, right? So investigations we should get the CT band. We have to check blood sugar level. We can go for the lipid profile, ECG, echo, carotid Doppler, and we have to start the antiplatelet therapy in these patients, right? So we can we can consider anticoagulation in this patient if the patient is having embolic stroke, right? So if the patient is having atrial fibrillation, we have to start the anticoagulation. We can give these patients novel oral anticoagulants, right? Okay, we have to treat the risk factor like diabetes, hypertension, right? And atherosclerosis. We're going to treat these patients. So we have to consider for carotid endarterectomy. We can get the color Doppler done of carotid arteries. If there is stenosis more than 70%, we can go for endovascular stenting. And avoid driving for 1 month after TIA, right? So that's all about strokes. So we have covered all the topics. So see you in the next video with the motor neuron disease. So our next topic will be motor neuron disease. So that's all for today.